Presentation on Disruptive Impulse Control and Conduct Disorders by Madison, Haley, and Frankie.
Hello, I'm Madison. I'm going to discuss the overview of conduct disorder. I'm going to read a direct quote from the Mental Health America that explains conduct disorder is a repetitive and persistent pattern of behavior in children and adolescents in which the rights of others or basic social rules are violated. The child or adolescent usually exhibits these behaviors in a pattern and in a variety of settings, places such as home, school, and other social situations. They cause significant impairment in his or her social, academic, and family functioning. Conduct disorder is also more common in males more so than females. In a history overview of conduct disorder, biological explanations were challenged by psychological explanations at the start of the 20th century as a result of increasing popularity of Freudian psychoanalysis. The first origin of conduct disorder was reported in 1880 due to social and legal problems of delinquency. The second period from 1910 to 1968, there is increased research interest in conduct problems of children, and researchers were attempting to identify the causes of these inappropriate behaviors. Conduct disorder became an official category in 1968. This was marked by a rapid accumulation in the knowledge around conduct disorders and developed treatment of conduct disorder. Conduct disorder was established in 1968 and published in the DSM-4. So here are a couple of snapshots of the DSM-4 versus the DSM-5. This overview explains the differences and the similarities between the two versions. A lot of the differences come from different behavioral patterns that are found to be more so associated with the differential diagnoses that Haley will get to later. But again, different behavioral patterns that will often be associated with conduct disorder, but wouldn't necessarily produce a diagnosis of conduct disorder. But again, we'll get more into that later with Haley.
And this is the criteria for diagnosis. So any of the individuals that will be diagnosed with the conduct disorder have to have 3 of the following criteria within the last 12 months, and at least one of the criteria must be present within the past 6 months. So the first category of symptoms is aggression to people and animals. So this could be bullying or threatening others, starting physical fights, using some type of weapon such as a knife, gun, or glass. They had to have been physically aggressive with other people or with animals, and they could have stolen from someone else through confrontation, or they could have sexually assaulted someone. Next slide. And the next category is destruction of property. So this is purposely setting something on fire with the intention of serious damage, or purposely destroying someone else's belongings. The next category is deceitfulness or theft, which is breaking into someone else's property, lying in an effort to receive something or get out of an obligation, or stealing something without confrontation and without breaking and entering. And then the next category is serious violations of rules, which can mean before 13 years old, they stay out past curfew. They've ran away from home at least twice or one time for a long period. And before 13 years old, they consistently were absent from school and were truant. And then the next criteria is that this individual must be displaying the symptoms that cause impairment in multiple areas of their life. So this can mean at school, within relationships, at home with their family, or if they're employed at their work environment. And then the next criteria is if they are 18 years or older, they can't meet the criteria for antisocial personality disorder. And if they do, then they should be diagnosed with that instead. Before a clinician diagnoses someone with conduct disorder, they should be sure to rule out all the other similar diagnoses that I'll be talking about on the next 2 slides. They should also obtain information from the individual, their parents, and their teachers if possible. And they should also ask how long these behaviors have been occurring. and whether or not they begin after a stressful event. So the first similar diagnosis is oppositional defiant disorder. This would be ruled out if the individual is exhibiting aggressive behaviors towards people or animals, destroying property, or is consistently involved in theft. I also included a little diagram on the side that kind of shows the degree to which problem behavior and which diagnosis would be applied. And then ADHD would not be efficient enough if the individual is exhibiting aggressive and violent behaviors. However, an individual can also be diagnosed with ADHD and conduct disorder. Depressive and bipolar disorders are another similar diagnosis. They can present themselves with similar outbursts in children with these disorders, but a children with conduct disorder would have a history of these behaviors before the mood disturbance occurred, and the behaviors will seem to be premeditated in conduct disorder. Intermittent explosive disorder is only for individuals whose explosive outbursts are reactive and impulsive rather than premeditated, and they also do not take part in these behaviors to obtain a good or service or to get out of an obligation. And then an adjustment disorder is only for individuals who are experiencing these behaviors as a result of some other event or stressor that took place within the last 6 months. If they don't resolve after the last 6 months, then after the stressor has disappeared, then the individual can be diagnosed with conduct disorder.
So here we have a case example of Mike. Mike is an 8-year-old boy who was recently suspended for the 5th time for aggressive and violent behavior towards other children. And this resulted in physical injuries. This could be cuts, blood, bruising, severe loss of impairment of other students. So that's actually violent physical injuries, not just regular normal injuries that you would see every day in school, especially for an 8-year-old. And he has just recently transferred to new school and has only been there for 9 months. So this is a fairly short period of time in which Mike has been at the new school, and he's already exhibiting these types of behaviors. Not only has he assaulted his peers in class recess, but he has also shown physical aggression towards staff members. And also, when he's doing this, he's also using chairs, pens, other objects that can really do damage and physical harm towards students and staff, not just fists, not just kicks. Mike lives at home with his mother and rarely sees his father apart from holidays. Mike's father has a history of antisocial personality disorder, alcohol abuse, as well as juvenile offenses. So there is some trauma and there is some differential between the parental figures within the home. Mike's mother works long hours and is often away from the home most of the day, leaving Mike to care for himself for long periods throughout the day. When the school reached out to Mike's mother and asked about Mike's behavior, she became hostile and blamed the school for lack of support. During this time, CPS was called by the school, and Mike's mother took offense to this, and therefore was hostile towards the school and staff ever since. When the CPS investigated this case, they found no suspicious reason to move Mike from his mother. Post-CPS visit, the psychologist reached out to the school to test Mike. The psychologist found it extremely difficult to test Mike because he did not cooperate and he had an inability to sit still and follow directions during the interview. Upon this, the psychologist then referred Mike to a children's hospital where he can be evaluated for further information and testing. I think this case example is extremely important because Mike is using severe physical assault and violence towards student and staffs, especially in such a short period of time, 9 months, and at his age, being 8 years old. He is really going through conduct disorder, and this is very, very dangerous towards not only himself, but the school staff and other students. Madison, I think you're muted.
Thank you. Okay, this is a slide taken from Johns Hopkins Medicine of how conduct disorder is treated in a child. Treatment will depend on the child's symptoms, age, and their general overall health. It'll also depend on how severe that condition is. So based on what Frankie was describing in the previous slide, he would most likely fall into that severe category. So different treatments for conduct disorders would include CBT, family therapy, peer group therapy, and different medications. In CBT, that child would learn how to better solve their problems, better communicate, and handle their stressors. This would also help them to cope and control with their impulses and anger. Family therapy is a great dynamic to help make those changes within the home to improve their overall communication and their interactions on a daily basis together. Peer group therapy is great because the child develops better social and interpersonal skills that will translate into their social situations, like their school setting. And then medications are not often used to treat conduct disorders, but a child may need them for other symptoms or disorders, one of the most common ones being ADHD.
And here we have implications of conduct disorder. So family history and genetic factors can really contribute to CD. As mentioned in the case example, Mike's father was alcoholic, juvenile records in the past, as well as personality disorders. Genetic factors can really play a role, and it can be passed down from parent to child. Drug and alcohol abuse can be prevalent in CD and can lead to further implications. So if a child is exhibiting conduct disorder, there is a chance that alcohol abuse and drug abuse can be present, that it can help fuel the fire, so to speak, in conduct disorder. Traumatic events in an individual's life can also be an implication of CD. PTSD can also contribute to conduct disorder and the reasons why individuals act out. Mental illness is a huge one, and it can be within one's family or self and can play a severe role in CD, not to get it confused with bipolar disorder or other mental disorders that are common and misinterpreted for conduct disorder. Impaired frontal lobe of brain can lead to impulsive behavior and lack of control of an individual with CD. So for an example, in an extreme case, as a child was beat when he was younger, his frontal lobe of the brain can form differently, or maybe he was in a car crash that can then lead to conduct disorder because the frontal lobe of the brain has not been fully formed yet. And at the bottom, it is always important to know that all individuals, regardless of a cognitive disorder, they're all humans and they all deserve empathy and respect of self, especially the very difficult humans that us social workers are tasked to deal with. And here we have our references for each slide.
Well, I'm sure you are now because I just said it. So let's talk about what it is exactly. For starters, did you know it's actually a mental illness that can affect up to 10% of youth each year? Did you say mental illness? But isn't there stigma with that? Well, actually, stigma are negative stereotypes that can prevent people from seeking treatment and in achieving a more complete and satisfying life. So let's get the facts straight first.
Because of the aggressive and destructive nature of conduct disorder, outsiders often assume that families of affected youth are chaotic, dysfunctional, and filled with interpersonal conflict. The tendency to blame child misconduct on poor parenting results in the failure to seek treatment. So rather than making assumptions and falling victims to stigma, we should educate, support, and encourage treatment. For example, in schools, teachers responsible for the care of affected children should collaborate with parents in facilitating positive outcomes. Through awareness and education, we can influence caregivers to take advantage of child mental health services.
So what exactly is conduct disorder?
Conduct disorder can be defined as a frequently occurring psychiatric disorder that is characterized by persistent patterns of aggressive and non-aggressive antisocial behaviors and deception. The population that's affected includes imprisoned youth who have a higher rate of conduct disorder, boys tend to have more frequently diagnosed than girls, and adolescents who appear to have a higher prevalence of conduct disorder compared to younger children. According to DSM-5, symptoms include aggression towards people and animals, destruction of property, deceitfulness or theft, serious violation of rules, and disturbance in behavior that causes clinically significant impairment in social, academic, or occupational functioning. In Canada, up to 4% of 9 to 17-year-olds are diagnosed, and it is more common in boys than girls and cities than rural areas. In the United States, up to 9% of 9 to 17-year-olds are diagnosed with conduct disorder. These numbers are approximate as comorbidity with other disorders is common. Awareness is important to enable early diagnosis and treatment, allowing for the greatest opportunity for success. With proper diagnosis and treatment, a child is able to navigate developmental milestones leading to successful adaptation to adulthood. Earlier implementation of treatment equals better outcomes.
So what if you don't seek treatment? Well, there's going to be ongoing problems in the future, such as not being able to adapt to adulthood, facing problematic relationships, having a difficult time holding a job, and having an increased risk for substance abuse and problems with law enforcement, and even developing a personality disorder in the future. So bottom line is, earlier treatment is always better. So what exactly does treatment look like?
Treatment involves a child speaking with a licensed and trained mental health care professional who helps him or her identify and work through the things that may be triggering the conduct disorder. The goals are to help the child learn to control and express anger in more appropriate ways that do not harm themselves or others. Psychotherapy is a common treatment choice. This includes cognitive behavioral therapy, which aims to reshape the child's thinking to improve problem-solving skills, communication, anger management, and impulse control. Another form of psychotherapy includes problem-solving skills training, which helps suppress undesirable behaviors and create structure in a child's life that provides security to build positive relationships as therapy progresses. There's no medication formally approved to treat CD, but various drugs may be used to treat some of its distressing symptoms. Stimulants, antidepressants, lithium, anticonvulsants, and clonidine have all been used in the treatment of conduct disorder. By improving attention and increasing inhibitory activity, medication may improve children's capacity to benefit from other psychosocial intervention.
So overall, don't let stigma stop you. And why should mental illness be viewed any differently than a physical illness? Just remember, whatever the mental illness, even for conduct disorder, that help is always out there. You'd be surprised by the amount of support you can get if you're just willing to take the first step to ask for it.